So this is just a general overview of heart failure with some kind of sprinkled in basic questions that you might have and hopefully to answer. So basically, what is heart failure? So there's two definitions that we use for heart failure. One is a weakness of the actual muscle. So there's decreased pump function. So the actual heart doesn't squeeze as well. And then there's the stiffening of the heart, which sometimes you might hear as diastolic heart failure or a stiff heart. So there's systolic heart failure, which actually means a weak heart where the ejection fraction is reduced. So most people that are healthy will have ejection fraction around 60%. And then when the pump function decreases, it goes somewhere less than that. And that can cause heart failure. And then, as I said, this diastolic or stiff heart is another cause of heart failure. So those are the two types that we separate between when we talk about heart failure. It's obviously it can be a very serious medical condition where the heart doesn't supply enough blood to meet the needs of the body. And there's terms out there such as congestive heart failure, fluid in the lungs, fluid retention, that are all synonymous or the same as heart failure or similar to. And so this is a little bit just terminology. So on the left here is a normal heart. This is the top right, bottom right, top left, and bottom left. This is the one that squeezes up to the aorta. That's the left ventricle. And that's the one we generally measure for that ejection fraction. Now, we also look at the right heart and measure the ejection fraction there as well. And so in the setting of heart failure, often the heart, especially in weak hearts, when it weakens actually, the heart dilates, so it stretches. And then the valves stretch and there's more leakiness, and the heart doesn't have that contractility that it used to have. And so this is when you get this dilated ventricle or a dilated heart, or what some people call dilated cardiomyopathy. And so then actually the amount of flow that is pushed out is actually reduced because of that. It's not as efficient. So heart failure is increasing. It continues to become a bigger and bigger problem in America and actually in the world. And it gets more common, and we see more of it as people age, particularly when we talk about that stiff heart, the diastolic heart failure. That in particular is what we're seeing more and more of now. But as people age, the prevalence of heart failure goes up. So what is it that causes heart failure? Well, the most common thing in our Western population is probably blockages or heart disease or plaque. In particular, things like heart attack can damage the muscle over time or weaken the muscle over time. High blood pressure can actually weaken the heart and cause heart failure. So hypertension is a very common cause of heart failure. I trained at Emory and at Grady, and probably 85 to 90% of people I took care of at Grady had heart failure from high blood pressure issues. So it's a very common cause if the arteries are not the issue. Things like alcohol or drugs, we see people with amphetamine use, cocaine, all that type of stuff. Significant alcohol use can affect the heart as well. Definitely heavy drinking is definitely cardiotoxic or damage to the hearts. Leaky valves can cause heart failure or weakness of the heart. So, the aortic valve, which is that valve that leads to the aorta, that can narrow with time and get really, really, really tight, kind of like a hose pipe where it's kind of almost clamped off and there's just a little bit of space for the water to go out of. So valves, either leaky or narrowed, can cause congestive heart failure as well. Fast, irregular heartbeats. So if you walk around with a heart rate of 150, 160 beats per minute for weeks, and you are diagnosed with atrial fibrillation or something like that, and you have a very fast heart rate for weeks and weeks, that can cause the heart to weaken. Congenital heart disease, which is growing because we keep seeing more people with congenital heart disease. Those are people that are born with heart defects that have surgery done, reverse the surgery, and then continue living and are living longer. We see those people develop potentially heart failure. And then rare conditions, which actually isn't as quite rare as I'd like to think, but things like viruses or even pregnancy, thyroid, and certainly familial or a genetic family cause of weak hearts. Those are all types of causes of heart failure. So what are the tests that we use to diagnose heart failure? So the easiest one is the EKG. You all know that we do those in the cardiology clinic just right there. That gives us some idea of the voltage and the forces in the heart, gives us an idea of the heart rate and the rhythm. Blood tests, you may have heard of something called a BNP, a brain natriuretic peptide. That's a measurement of blood test that is released from the heart that we can actually test. And that gives us an idea of how stretched the heart is. And that BNP, when significantly elevated, tells us that the heart is stretched and the pressure in the heart is elevated. An ultrasound of the heart, which is the goop on the chest that we do upstairs in cardiology clinic, gives us an idea of the heart function, both the left side and the right side. And finally, often cardiac catheterizations, where we go through an artery and or vein to determine what the arteries look like, either in the wrist or the groin, and then also to check the pressures inside the heart. So those are the kind of common bread and butter cardiology procedures that end up being the patient might go through when diagnosed with a weak heart or congestive heart failure. So what are the effects of heart failure? So first, it's again not enough blood getting to the body, which often may cause fatigue. Blood might back up, and the pressure then kind of is transmitted down into the belly or into the legs, and then the blood actually kind of spills into the tissue, and you get swelling in the legs or swelling in the belly. Now, there's other causes for swelling in the legs, a lot of other causes, and so it's not just heart failure that can do that. Sometimes people with liver problems or kidney problems or even just reflux of the veins in the legs can cause fluid to spill back in the legs. So that's not, oh, I've got swelling in my legs, I must have heart failure. But that is kind of a common thing we see in people with weak hearts. Things that really symptoms that people can get when they have a weak heart or are in congestive heart failure include shortness of breath. I have a lot of patients that tell me, going up a flight of stairs just wipes me out, or going to the mailbox. Sleeping flat in the bed. So when you're sleeping flat in the bed, all that fluid in the arteries and the veins and stuff in your lungs actually can kind of seep into the lungs themselves because the pressures are high there. So people get short of breath and feel like they're choking. And so they commonly add pillows to be propped up so that the fluid can better stay up rather than go dependently down into the lungs. And so inability to sleep flat in bed is something I screen for patients, when they're telling me about their symptoms. Cough. So when the pressure is high in the heart and lungs, people cough. Weight gain. So if you may not be hungry, you may not be eating any different, but there is a weight gain associated with the swelling and such. And finally, swollen ankles, legs, and abdomen are all potential causes or symptoms of heart failure. So other symptoms of heart failure. So you may have tiredness and fatigue, dizziness, rapid heart rate. And then there's the symptoms of advanced heart failure. These are, concerning symptoms for me and Dr. Telsa when we hear about people losing weight. Their appetite is worse. They get full very, very fast. Muscle wasting. Those indicate a more severe disease process or more advanced heart failure. Usually that is, we have to kind of expedite our workup, potentially, get to an advanced heart failure center because there's something that probably we cannot provide just with medicines. Heart failure encompasses a lot of things, and that includes emotional symptoms such as depression and anxiety. About 15 to 20% of people with heart failure actually have depression as well. And so oftentimes we screen for that with these questionnaires in our clinic. We've picked up a lot of depression. I tend to try to treat that myself. I have a psychiatrist who I work with, who's part of our behavioral health, that's part of our heart failure team. And that behavioral health person comes to our meetings, and she helps guide therapy. And if I feel like the person really needs to see a psychiatrist, they help facilitate that. Because this is not something that we should neglect, or we can neglect. Because when you set aside the depression and the mental part of heart failure, people don't take their medicines as well. They're not motivated to deal with the lifestyle. Everything is more difficult if you're mentally having a hard time with the diagnosis. So that's why we want to not miss that as well. So it's important to monitor these symptoms on a daily basis. And if you notice something new or worse, with the shortness of breath or the increasing swelling and such, then that's when you kind of have to talk to us. So what is my prognosis? So the prognosis is unpredictable, but over the past 15 to 20 years, the medicines have done so much to stabilize and improve people with heart failure that the condition is completely changed since 20 years ago. So in the late 80s, early 90s, when I was in middle school or elementary school, people would give Lasix and digoxin, and that was kind of it. Beta blockers like metoprolol and carvedilol weren't around. Lisinopril, losartan weren't around. Spironolactone, aldactone wasn't around. All these life-saving medicines that we know help kind of flatten the progression of heart problems and symptoms were not around. So it certainly, in the outpatient setting, changed a lot for people that have this disease. And that's what I tell my patients the most, that now, it's a little different when people are admitted every month or whatnot into the hospital. Those people still seem to not do great. But for people that are managed as an outpatient with this diagnosis, with an occasional admission, it seems like the prognosis is really excellent. And people live years and years with this. Defibrillators weren't around. 15 years ago, defibrillators weren't around. So all these types of things that have come around in the past 10, 15 years have prolong people's lives significantly, and quality of life as well, of course. So what can you do? First, it's a chronic condition. It requires time for the medicines to work, the lifestyle to be understood, all that. So that was why we kind of set up the heart failure clinic in some ways, is to kind of make sure that we address some of these lifestyle changes. Even that's why we have this class, so that people get even more info about the dietary changes that you have to make. The benefits of exercise, alcohol cessation, and obviously smoking cessation. So those are all obviously lifestyle modifications. What else can you do? Well, medicines. And I have a lot of patients, and they always say, you give me another pill, doc. And yeah, I am. But these medicines, those three, the beta blocker, losartan, lisinopril, and spironolactone, have changed the way people live. And so what can you do? Well, you can take the medicines that we tell you to take every day. Obviously side effects, there are issues, and we try to work around those and get people to tolerate stuff, or change the doses, or change to a different cousin or whatever of the medicine. Bring medications or a list of your medicines when you come to the clinic. I think that's very helpful. We find all kinds of mistakes in the chart. I thought I was taking it 2.5 instead of 5, or 5 twice a day instead of 5 once a day. So bringing your medicines or a list of medicines, I think, is great and always very helpful for me, for Carla. And then obviously refilling the prescriptions on the right time. So, sometimes I see people say, I ran out a month ago, I just haven't made it around to going to get it filled. You can't do that. Particularly with some of these drugs, because when you wait on that, that's when you kind of get into problems and you end up in the hospital. So many admissions to the hospital are because people run out of their drugs, out of their medicines. And the body gets used to it, we've got things stabilized, and then you take away everything, and then you're next 5 days later in the hospital for 5 days. So, refilling your meds, kind of planning in advance, knowing when you're almost out of pills, using the online refill, all that type of stuff. Monitoring your weights. So this is important. In general, weights give us a good sense of the fluid balance of the heart. And so over a length of period of time, we can kind of tell how the fluid is building or not building up based on the weight. And so, most of y'all, or you all, should have a scale that Sherry gets for you. The scale talks to you, which some people hate, so and they yell at me for that. But I didn't choose the scale or the company. So, but it's important to monitor the weight. It's important to watch your blood pressure if you have a blood pressure cuff, because we can, change your medicines by phone. It saves you a trip up to see a nurse potentially if you do have an accurate blood pressure cuff. Regular checkup and blood tests. These medicines do have effects on the kidneys, so it's important to get the routine blood work done when asked. And then also things like the flu shot and the pneumonia shot. Those diseases or infections, that's what kills people with heart failure. It doesn't kill the 24-year-old, on the street just walking around. The flu kills people with heart failure or with weak hearts. And so in particular, it's important for people with heart conditions like to get flu shots and pneumonia shots, and that's why I yell at y'all to make sure and do that over and over, because it does, save lives. What else can you do? So keep your other medical conditions controlled. So high blood pressure. It's important to have the blood pressure down under 140. If you have a weak heart, your blood pressure is not supposed to be 120. If you have a very weak heart, it's actually, I'd like it to be around 100 even, 90, as long as you feel okay, as long as you're not passing out, as long as you're not sleepy all the time. So the heart, when weakened, doesn't need to fight against a stronger blood pressure. It actually makes it harder on the heart. So we like to push the medicines to where someone tolerates the dosage, but is not feeling bad with the dose. So that's important for controlling the blood pressure. Diabetes, obviously having your A1C checked and working with primary care or with an endocrinologist or the diabetic nurses to make sure that the sugars are good. The cholesterol, a lot of these conditions are concomitant. So, if you smoked for a long time, we need to make sure that you don't have COPD contributing to the lung. So I send a lot of people for those pulmonary function studies, especially people with smoking history. Thyroid problems, as I said, thyroid can cause weak hearts. High thyroid and low thyroid can cause weak hearts. And so often treating the thyroid actually takes care of the heart condition. And so kind of working on the thyroid if that's an issue. And then obviously depression, as I mentioned. So you can continue to live active and fulfilling life. So you can do things that you want to do. You can go to the gym. You can go on vacations, et cetera, if you have a diagnosis of heart failure. The key is to be active in your management of your condition. So you taking charge, working with our team, working with Sherry, working with either me or Dr. Telsa on all those dietary lifestyle modifications. Having a good support system is really important. So if you're not used to coming with your spouse or whoever, bring them to the appointment. Okay? I get more nervous about people that show up solo when I don't know them than if I bring somebody, because I don't know if there's anybody there to harp the stuff that I say to the person. So, and it sounds bad, but that makes a difference. So, if it's a first appointment or whatever, or you just need someone there to help re-emphasize the things that I say, because we talk a lot, we talk about a lot of things, it's always good to have another set of ears. So some common questions. Can you travel? The answer is yes, you can travel. If you get a defibrillator, the airport's going to want to know because they have the metal and all that type of stuff. You got to get your card out. You got to tell, the people, I've got a pacemaker defibrillator. You got to pull your card out. So there's a little bit of planning in that, but yes, you can fly. I had somebody travel with a life vest on, which kind of looks like a bomb if you think about it. So it's a vest on the chest. And he had to fly up to Pennsylvania to be near his family, and so we had to write all kinds of notes and all that type of stuff. But he traveled, and it was fine. So the answer is yes. With the proper documentation and kind of pre-planning a little bit, you can definitely travel. Can you drive? This kind of depends on situations. By Georgia law, if you were to pass out from an arrhythmia or from a rhythm problem, and it's documented that it was an arrhythmia or it was assumed that it was an arrhythmia and you passed out, you can't drive for 6 months, period. That's the rule. So if you've had a defibrillator firing, you can't drive for 6 months. So there are some legal rules out there because, you could imagine if you've someone whose device or defibrillator fired multiple times recently, you don't want to be driving the car and be driving while the device fires. So can I drive? Most everyone can. But there are some exceptions, particularly involving passing out spells or arrhythmias that sometimes go along with heart conditions like congestive heart failure or cardiomyopathy. Can I continue to work? A little bit, again, of an individual situation, depending on often what you do for work, where you work, can you be on light duty, when are you in your disease process. In general, I try to keep people working if they can because it gives them some sense of normalcy or normalcy. But there are clearly exceptions. I've got one gentleman whose ejection fraction is 20-25%, and he does heavy machinery, and he lifts 100 pounds and is a mechanic for City of Atlanta on trucks. He's going to have a hard time, and so there's clearly, things with certain job descriptions that may not work with what you do. And so you have to kind of work with either me or Dr. Kelsa regarding that. I tend to try to get people to continue working if they can, but I tell them they have to listen to their body and know what's going on. So if you're very debilitated and you can't, then you can't. And if we've got the documentation shown that that's because of the heart condition, then it's all the processes with working with Sherry and disability and all that type of stuff. How about effects on relationships? So I think the point of this slide is basically, this can be a strain. There can be caretaker type of strain with patients and their spouses. If someone's very sick, they need a lot of help. They need, constant attention, things like that. Some people kind of get a little grumpy with their caretaker, right? So I had a patient that called her daughter the warden, because she's very strict on all the food that she eats and all that type of stuff. I think she says that in a lovingly way, but at the same time, that's sometimes you need that extra motivation and push that someone else can't. That you might want to eat that bag of potato chips that has 600 milligrams of sodium, and you just say, "Oh, that one time," and someone's there to say, "Hey, do you really want to do this?" I think we all kind of need that, so it is important. So how about warning signs from congestive heart failure, weak hearts, et cetera, et cetera? So when should you seek medical attention? So obviously persistent chest pain not relieved by nitroglycerin. This is particularly true, obviously, if you have heart blockage disease. So if you think you're having a heart attack, obviously, things like that, you got to go get help. Severe persistent shortness of breath. You can't get comfortable sleeping. You've got to be propped up. You notice fluid. What we don't want is people to wait till they're 20 pounds over their dry weight and call us and say, I think something's wrong. Because that pretty much will guarantee an admission to the hospital. What we want to kind of do is catch things a little bit earlier. And so when you're just starting to notice that fluid is building up or you're feeling something's kind of different. So that's important. Now passing out. Passing out, can be a very scary thing to patients with weak hearts. There's different types of passing out. So, my first day, and as a med student, I think as an intern at a clinic, I was doing an exam on somebody, and I hadn't eaten anything, and I was moving stuff out of my apartment, and I was tired, and I got lightheaded and weak and nauseated and sweats, and I felt it coming on, and then I passed out. That's usually something called a vasovagal, or what's a common cause for passing out. Walking down the street, and the next thing you know, you're on the ground and you've hit your head and you don't know anything that happened. That's not normal. That is a scary kind of passing out. That's an arrhythmia, potentially, type of passing out. So those types of things, is what we want to know about immediately. Because we know people with weak hearts are at risk of arrhythmias. That's what often kills people. That's why we do the defibrillators, et cetera, et cetera. So passing out is something you want to let us know about for sure. Rapid weight gain or increased swelling despite diuretics, that's an important thing for us to know as well. And finally, significant loss of appetite. So you feel that your appetite just isn't there, even though you're wanting to eat, but you try to eat, you just feel full fast. All those are kind of, as I said, signs of potential advanced heart failure. So we need to know that. Okay, and that's actually it.